thought process. Then went into a lot of research on great textbook, and even though I was at other classes, I didn't came to conclusion what is the diagnosis. So I thought that very simple thing, but still the patient is still without any diagnosis. So I thought let me present that short case and followed by literature. This patient was a 16-year-old boy. He was a student and football player. Every day he used to play 2 hours of football, an aggressive football player. He presented with the swelling and mild pain on pressure near elbow, left elbow. There was no respiratory issue, no fever, vitals were normal. On examination, there was a crepitation on palpation around forearm and elbow. Chest X-ray was normal and CT chest was normal. Count and CRP was normal and other parameters were normal. This was a CT of forearm and left hemithorax. There was no pneumothorax or pneumothorax or anything. There was near elbow, you can see air around the subcutaneous tissue. There was no history of injury to the left upper lip, no history of even stretching.
How did patient come to you? Being a cardiologist.
Patient is basically from Vaghela, so there are some pulmonologists who see that. So he referred that patient to orthopedic surgeon. Orthopedic surgeon referred me after seeing this that I don't think anything is wrong with the bones and the muscular tissue, but there is something related to chest. So please rule out. So he was my friend, so he referred to me. After examination of thorough clinical examination and I took almost 45 minutes to sit with that patient. I didn't find anything wrong with his chest. Not toxic. Absolutely fine. His saturation was 100%. Something.
So, 2 things are there. Toxic air getting continued.
Absolutely.
Right? But patient was not toxic. It's not toxic. Patient
Patient
had
was
no link with the air connection of the lungs.
And then the low blood was corrected in 3 days before that.
I'm coming to that.
And local signs of inflammation.
There was only little tissue crepitation and deep application of pressure. There was a pain. Though there is no restriction of movement, there is nothing related to musculoskeletal and skeletal.
No obvious signs of inflammation.
There is no inflammation. Only on deep pressure, the patient was saying that okay, I am having a little bit pain. That's all. Nothing else.
And there was swelling.
And there was little swelling, not much. On palpation,
But then you had a sense of crepitation.
crepitation was definitely there, and I have tested that crepitation back up to where it is going. So I could find it was going up to middle of the humerus. That's all. And that one, a middle aspect it was more, and a little aspect it was more. So I thought that there is no muscular injury, there is no manipulation of the elbow, there is nothing. What can be? So I thought in the line of infection. So either it can be a gas-forming organism or something. But how that goes in? So I detailedly inquired that have you taken any injection in the class? So he said that 7 days back I underwent typhoid vaccination. And it was injected from cubital vein. And there was that he detailed he was not knowing.
Typhoid is the most of the time intramuscular. It's the intramuscular oral vaccine.
He's not knowing what kind of vaccine was given.
What vaccine he was, but he said that I have taken a treatment for typhoid. Now, around the injection site, there was little edema, there was little swelling, and it was a little scab was there. So probably it was injection was given with a
Symptoms or something.
Now, what was there, we really don't know. Even now, after almost 11-12 days, the patient is having crepitation and it has gone up to humerus. So, movements are normal, nothing. So, I have just allowed, I told him that you consult some physician because tetanus came into my mind. You have to rule out clostridium because I had a limited knowledge, so I advised him to consult the physician in January. They are regularly in touch with me, and then it inspired me to what can go wrong. Absolutely, and I said that if you develop any respiratory distress or something like that. So, gone through a lot of literature. Usually the Clostridium organisms are responsible, especially exotoxin producing organisms like Crepitation, Novi, Septicum, and Rhamnosum. Even some gut flora, anaerobes, and sometimes in diabetic capsular pneumonia. I have never come across any typhoid organism, which is usually a gas forming organism, but not come across in a clinical situation again. The gas composition is usually 5.9% hydrogen, 3.4%.
It is in laboratory.
In a laboratory.
Fermented produce or fermented small produce.
Absolutely. So, subcutaneous emphysema is when the gas or air in the layer of under the skin. The subcutaneous refer to the tissue within the skin, and emphysema refer to trapped air. Because I was not knowing whether I should label that as an emphysema or not. Emphysema is usually related to chest, but then I went into literature and then I found out that any entrapment of air is labeled as emphysema. It may not be related to chest. It is sometimes abbreviated like SCE or SE, or also tissue emphysema or sub-Q air. The radiologist label as a sub-Q air, physician label as a SCE, cardiothoracic referred as a SE. Depending on our practice, people differently say the terminology. Since the air is generally comes from the chest cavity, and subcutaneous emphysema usually occurs on the chest, neck, and face, where it is able to travel from chest cavity along the fascia. Subcutaneous emphysema has a characteristic crackling feel on the touch, and a sensation that has been described as similar to touching a Rice Krispies. This sensation of air under the skin is known as subcutaneous crepitation. Numerous etiologies of subcutaneous emphysema have been described. Pneumomediastinum was first recognized as a medical entity by Lanek in 1890, and later in 1939 in John Hopkins, the postpartum case, Dr. Human diagnosing one woman, and that was known as a Havan syndrome. Then later in 1939, in some medical circle, it was instead be more commonly known as Macklin syndrome after Macklin diagnosed pathophysiology in more detail.
Now, Vaghela syndrome.
No. Subcutaneous emphysema can result from puncture of part of the respiratory system or gastrointestinal system or gas forming organism, particularly in the chest and the neck, and air may become trapped as a result of penetrating trauma like gunshot wound or stab wound or blunt trauma or infection in the subcutaneous tissue. It can be caused by medical procedure or medical condition that can cause pressure in the alveoli of the lung to be higher than the tissue outside the lung. Its most common cause are pneumothorax and the chest tube that has become occluded by the blood clot or fibrinous material. And in our setting, we see a lot of times because the chest tube is blocked, we see a lot of subcutaneous emphysema. It can occur spontaneously due to rupture of alveoli with the dramatic presentation. And the thing is that the moment the patient develops subcutaneous emphysema, they start distrusting a physician. Immediately they will ask for a second opinion. We wanted to go somewhere. Because the development of subcutaneous emphysema is so rapid and the whole face and neck become edematous. And they consider normal laymen consider the ominous sign. And that's the reason that we have to treat it, we have to explain to them in detail that what exactly is subcutaneous emphysema is there. When the condition is caused by surgery, it is called as surgical emphysema or iatrogenic emphysema. The term subcutaneous emphysema is used when the cause is not clear. It is very clearly written in the literature. If spontaneous subcutaneous emphysema is used when cause is not at all clear. Subcutaneous emphysema is not typically dangerous in and of itself. However, it can be symptoms of very dangerous underlying conditions such as pneumothorax or gastroenteritis. Although underlying conditions require treatment, subcutaneous emphysema usually does not require any treatment. Small amount of air can be absorbed by the body. However, subcutaneous emphysema can be uncomfortable and may interfere with the breathing, or often treated by removing air from the tissue, by example, using large bore needles, skin incision, subcutaneous catheters. Signs and symptoms. Usually, subcutaneous emphysema is very vague, largely based cause, but it is often associated with the swelling of neck, chest pain. Sometimes it is involved with the sore throat, neck pain, difficulty in swallowing, wheezing, difficulty in breathing. X-ray shows air in the mediastinum or middle of the chest cavity or in a peripheral pneumothorax. A significant case of subcutaneous emphysema is easy to detect by touching the overlying skin. It feels like a tissue paper or rice crystal. Touching the bubble causes them to move and sometimes make it crackling noise by bursting that air bubbles, and that is the reason that we feel crepitation. The tissue surrounding emphysema is usually swollen when large amount of air is in the tissue, and the face can well considerably swell. In case of subcutaneous emphysema around the neck, there may be feeling of fullness of neck, and the sound of voice may change, hoarseness of voice. Particularly in extreme around the neck and chest, swelling can interfere with the breathing. The air can travel to many parts of the body, including the abdominal limbs, because there are no separation in the fatty tissue in the skin to prevent air from moving. It can go right on the face, it can go in the pelvis, it can go in the leg extremities also. The causes are blunt trauma, penetrating trauma, around often in road traffic accident. If seatbelt is not on, the force crash that can cause high level of blunt trauma and can have elevator injury without having the chest injury. The chest trauma is the major cause of subcutaneous emphysema and can cause air to enter the skin of the chest wall from the neck or lung. When the pleural membrane is punctured and occurs in penetrating trauma, the chest air may travel from lung to the muscles and subcutaneous tissue to the chest wall. When the alveoli of the lung are ruptured, as occurred in pulmonary vessels, air may travel beneath the visceral pleura, the membrane, and to the hilum of the lung and to the trachea, and from there it goes to the neck and other chest wall. Here the condition may also occur when the fracture will puncture the blood. And in fact, 70% of the fracture you will be able to palpate crepitation because of the subcutaneous emphysema. Subcutaneous emphysema is frequently found in pneumothorax, air outside of the lung, in the chest cavity, and may also result from the air in the mediastinum or pneumopericardium. Tension pneumothorax, in which the air builds up in the pleural cavity and exert pressure on the organ within the chest, can make it more likely that air will enter the subcutaneous tissue, the pleura torn by the bronchiole. When subcutaneous emphysema results from pneumothorax, air may enter tissue, including those of the face, neck, chest, armpit, or abdomen. As I said, pneumomediastinum can also result from the foreign body aspiration and because of the esophageal injuries or gastric injury. It can also occur because of the barotrauma in a deep sea drivers. It was initially in 1819, late 18th century in US Navy they identified this condition. Trauma to the part of respiratory system, like rupture of the bronchial tubes, can have developed this type of thing. Air may travel upward to the neck and pneumomediastinum that result from bronchial rupture, or downward from the torn trachea or larynx to the soft tissue of the chest. It may fracture of facial bone neoplasm during asthmatic attacks and when Greenwich maneuver and during the childbirth. It was estimated that during the childbirth, postpartum, pneumomediastinum in 1 in every 2,000 to 1 lakh deliveries in US. Injury by pneumatic tools, especially dental surgery, they use pneumatic tools during the cavity making or pneumatic tool which is being used during surgery like laparoscopic instrumentation or laparoscopic manipulation. Those driven by air is also known to cause subcutaneous emphysema. It can also occur as a rupture of esophagus, as I said, and it is a very late sign. Now, coming to the medical treatment, the subcutaneous emphysema is a common result of certain types of surgery. For example, it is not unusual in a chest surgery, and it may occur from surgery around the esophagus, and particularly likely to prolong the surgery. Oral surgery, laparoscopy, not a medical treatment, because cause during the medical treatment, like chest surgery is very common, oral surgery, laparoscopic surgery, cricothyroidectomy, the pneumonectomy. In that, if the stump of bronchial, which is the suture, it is leaking, and the patient develops massive pneumonia. And even dental surgery, you can find a lot of pneumothorax or anything. One of the main cause of subcutaneous emphysema along with the pneumothorax is improperly functioning chest tube. As I said, the subcutaneous emphysema often a sign of something wrong with the chest tube. It may be clogged, clamped, out of place, or sometimes it is come down. The tube may need a replacement, or large amount of air are leaking. The new tube is to be added. Another thing is mechanical ventilation. It can cause surgical emphysema. Tracheostomy and tracheal intubation, especially difficult intubation and endotracheal intubation. At that time, trauma to the trachea and bronchus can occur. Other causes are gas gangrene, necrotizing infection. It is a late sign and it is a hallmark. If you find crepitation in the site of infection, you have to have a high index of suspicion regarding gas gangrene. Scrotal gas gangrene, it is also known as the corneal gangrene. This is considered as a hallmark sign, crepitation. Symptoms of subcutaneous emphysema can result from organism produced by gas fermentation, and it can present in the other location, and blood culture can be possible. Now, pathophysiology. Air is able to travel the soft tissue of the neck from the mediastinum and retroperitoneum, the space behind the abdominal face, because these areas are connected by facial plates. From the puncture lung or airway, the air travels up to the perivascular sheath and into the mediastinum, from which it can enter the subcutaneous tissue. From the chest, how can the air go to the subcutaneous tissue? That comes into our mind when the chest cavity is intact. So it goes to the perivascular sheath, and from there it goes to the subcutaneous tissue. Spontaneous subcutaneous emphysema is thought to result from increased pressure in the lung that cause alveolar rupture. In spontaneous subcutaneous emphysema, air travels from the ruptured alveoli into interstitium and along the blood vessel of lungs into mediastinum, and from there into tissue of head and neck. I have gone to a lot of literature. I found one classification that grade 1 is just spontaneous surgical emphysema in the neck. Grade 2 is neck, lower neck and upper chest, above the clavicle, then entire neck. Then grade 3 is chest, especially anterior chest. Grade 4 is chest, tactile region, infraclavicular, supraclavicular, and entire neck. And grade 4, there is entire abdomen, chest, upper arm, and the neck, and sometimes the head, and even the scrotum. You can see this picture of bubbles of air in the subcutaneous tissue feel like more mobile nodules that move around easily. on palpation. X-ray chest of chest patient, and air can travel up to pelvis. You can see the hip region and both the scrotum, there is a subcutaneous emphysema. Now coming to the diagnosis, radiographically X-ray, radiolution striation is a pattern expected from the pectoral muscles group in a chest X-ray. Air in the subcutaneous tissue may interfere with the radiology of the chest. Underlying chest pathology you won't be able to identify very easily on radio X-ray. When you have a surgical emphysema or emphysema, subcutaneous emphysema. Ultrasound, because of the air, it interferes in the signals and it won't give effective diagnosis. However, to diagnose surgical emphysema, ultrasound is just not useful. CT is the most important diagnostic tool. With the air pocket appearing in the dark area, CT scan is so sensitive that commonly make it possible to find exact spot from which air is entering into the soft tissue. For that, we require very good radiologists to identify source of air bubbles. These investigations, medical imaging, are used to diagnose condition or confirm our diagnosis made using clinical science. Treatment usually it is benign. Most of the time, this emphysema does not need treatment through the condition which, but what is required is underlying cause of the subcutaneous emphysema to be treated aggressively. However, if the amount of air is large, it may interfere with the breathing or be uncomfortable. It is occasionally progressive state of massive subcutaneous emphysema, which is quite uncomfortable and requires surgical drainage. When amount of air pushed out of the airway or lung become massive, usually due to positive pressure ventilation, the eye swells so that the patient cannot see. Also, the pressure of air may impede the blood flow to the areola of breast and skin of the scrotum and labia, and this can lead to necrosis of the skin on that area. The later are urgent situations require rapid and adequate decompression. So, when we should do rapid incision or puncturing of the skin or drainage catheter insertion in grade 4 or grade 5, not in grade 1, 2 and 3. 1, 2 and 3 can be treated conservatively, or if there is a respiratory distress. The indication of drainage is respiratory distress. Edema is so massive that you cannot see. Massive air leak, you have to put a chest tube, and if edema is traveled up to scrotum and lower labia, because of the tissue necrosis can occur. In severe cases of subcutaneous emphysema, what we normally do, we put small cuts or blow holes with a 18 or 16 gauge needle. Sometimes we put a cut and sometimes we put small needle. Catheter also we have put in a subcutaneous tissue, our simple Romson drainage tube, which normally we put it in the chest because it has got a multiple holes. We put a small incision in the pectoral region and then push that chest tube in the subcutaneous tissue and apply suture or nearby to hold that tube in the proper position. And most important thing is we have to mark with the pencil. The skin pencils are available in the market. We have to mark the area when we see first, so that we can make a progress whether it is increasing or it is decreasing. Since the treatment usually involves dealing with the underlying condition, what we require is a bed rest, medication for control of pain, supplementation of oxygen. Now, breathing oxygen may help to absorb more faster subcutaneous air, and they recover very fast.
The role of hyperbaric oxygen?
There is a role, but I have not come across any scientific paper on that. There is a role.
But where is the hypoxia? There is no hypoxia.
There is no hypoxia.
No, but aircraft should get absorbed faster because
that is what he has
Gas chamber is the differential.
yeah.
See, the gas.
Why that not?
Hmm?
Why that
which will absorb air very fast. That's what we observe. Normally, I have observed that what is the rate of diffusion. Suppose the patient develops surgical emphysema grade 3. So how long it will resolve? Normally, patient will have so that answer even I don't know. But what I have observed that it takes 3 to 4 weeks to completely become normal. Once you put a chest tube or whatever management.
In your patient, what is that?
3 to 4 weeks. 3 to 4 weeks.
Nothing.
case હવે આ પતિ જાય પછી we'll discuss. કારણ કે it is an entirely different case, not related to case.
No,
case.
that
It is
is
an
over.
entirely different case.
Even today, that it has gone up. Yesterday only I telephoned and he only sent me pictures. After 48 calls, I got the contact number of that patient. He sent me all the pictures. It has gone up to humerus, just below the humerus. But swelling is still there. I just advise him to rest and after 1 week exercise chest and respiratory issues come. And repeat CRP and consult some physician to rule out tetanus and we have given a broad coverage antibiotic coverage.
It is no that it was mentioned in animals.
That is very important. One of the commonest cause air embolism is usually after air embolism occur in a intravascular space. But yes, laparoscopic air embolism is very common and it can create
For a female when the deliveries are being done as such. Because it is a highly vascular tissue. Here there is no vascularity that much.
So, sir, that is an entirely different topic. Air embolism is
No, this much air absorbed and not producing air embolism.
Air embolism માટે you require minimum 100 cc of air simultaneously.
No, sir, question is that.
Can
create air embolism or not?
Bolus.
Bolus of 100 and bolus of air can cause air embolism. If this subcutaneous air is getting absorbed, it is getting slowly absorbed very slowly.
See, the reason is, probably this is my thinking, that there are channels for gas absorption also. And like ion channels, there are gas channels. Gas never pass by itself as such. And because the channels are intact, it passes slowly, absorbs slowly. If it absorbs very fast, like a trophoblast, then it is open as such, in placenta, maybe or somewhere else, and maneuvering.
My question is the alveoli is ruptured. How will you heal it up? Or if one of the causes is the rupture of the alveoli, will it not go on?
Tension unless.
So usually it heals because you see, moment alveoli puncture, because the pneumothorax, the whole lung will collapse. Because the whole lung is collapsed, that area of the automatically compressed by other alveoli. And once you put a tube, what happens? The pleural adhesion will start. It will heal. It takes 3 to 4 days to even minor puncture. So normally what we do is, suppose there is a pneumothorax with minor hole in some puncture, minimal air, we put a tube, we keep the tube for 24 hours, and after 24 hours, lung is expanded, no colon movement, I clean the tube and keep the tube for another 24 hours. And next day morning, I take another X-ray to see whether the leakage is still there or not. If there is a leakage, I open the tube so that I don't need to put a tube again.
Now that demography is changing.
Yeah.
Previously we were aspirating and then the subcutaneous emphysema as such, like pleural effusion, inadvertently, right? Which was very common. Now iatrogenic is coming down rather than gastric.
Absolutely.
And that is in pneumoperitoneum by the laparoscopy as such. Cavity by the dental people as such, pneumatic things. Means that now the pattern has changed as such.
Now most of the time I am saying is iatrogenic. I have been called by urologist while doing PCNL. I have been called orthopedic surgeon while doing some spine. I have been called by neurosurgeon on the theater that patient is developing distress and on X-ray there is a pneumothorax. I have been called by laparoscopic surgeon that while we had a long procedure and we found that there is air in the chest. So many times they call and we go there and put a tube and come out and after 40 days everything will be fine. It usually does not cause any lethal fate. small amount of air can be absorbed by the body. And once the pneumothorax or pneumonia syndrome that causes the subcutaneous emphysema is resolved, with or without medical intervention, the subcutaneous emphysema usually clears over a period of 4 to 6 weeks. So I still didn't came to conclusion regarding that case. This is our presentation.
The thing in your case, this subcutaneous emphysema is not related to the case.
No.
That is very clear.
Very clear.
The other, if we go by the literature, there is no pneumatic drill which is involved in causing, and then ultimately to suspect some gas forming out.
ये पहले इंजेक्शन आपकी वक्त ये नर्स ट्रेन ना हो हाँ એટલે પ્લીઝ એડ and I also don't know whether
not properly, air was not.
And another thing is very interesting. I asked who put that typhoid. So he said that government hospital.
But typhoid vaccine is never IV,
I don't know whether it's right now it is by expand. So come on, चलो ठीक है.
ठीक है ना क्लिनिकल पेशेंट मस्ट हैव डेवलप
Exactly. उन्हें एक diagnosis.
थायराइड हेल्थ एक्सेप्टली
patient was not toxic. हाँ अरे hours में के लिए हाँ आइडिया इंट्रावेस्कुलर हाँ वेट कोर्स not in hours 100% possible. Three questions came in my mind, which I properly searched, which I couldn't get answer. Number one, what is the duration of total disappearance of subcutaneous emphysema? Which probably over a period of time, if I search and if I found, I will let you inform. Number two, in a current scenario, suppose in such case, which I have presented, comes, whether to put ICD or not, still I am not comfortable to put ICD in that position. But definitely a close association with the physician or pulmonologist and whether to have an intervention. I really don't know. And whether, I wanted to know from you guys that whether this tetanus or typhoid vaccine cause gas pneumonia or any subcutaneous infection or not.
So what
because it is a gas forming organism which is there.
So typhoid organism are gas forming.
Commonest in the Clostridium. They are grand causes gas forming organism.
It should be better. Crepitation.
Absolutely.